we move on to the next talk, is also very interesting. Medicate or meditate. So that's the conundrum in type 2 diabetes. And to talk on this, we have none other than Dr. M.A. Shekhar. Sir is Honorable Vice Chancellor of the Nagari University. He is the former Director of Karnataka Institute of Endocrinology and Research, Bengaluru. He is the former Professor of Medicine and Head of Department of Endocrinology at Mysuru. He is the Director and Consultant Diabetologist, Apurva Diabetes Foundation, Mysuru. He has been the Member Governing Council, Mysore Medical College and Research Institute. He has a number of achievements to his credit. He is invited faculty at various conferences, CMEs, universities. He is author of chapter and editor of books on diabetes. He has published papers in peer-reviewed journal. We are indeed honored and privileged to have you, sir, as speaker today. And over to you, sir, for your talk.
Thank you, boss. Well, good evening, everyone. It's my pleasure to be a part of this great activity that's going to happen for 2 days. For that, I'm extremely grateful and I'm thankful to Dr. Vaishali, Rachi, and Harpreet, who literally have held my hand and took me to this place so far in the last 10 days. Thank you all for this. And let me share my slide, okay? Visible?
Yes, sir, visible.
Thank you. Now, this is where I am the Vice Chancellor presently, Adi Chunchanagiri University. I bring greetings from the university, Jai Shri Gurudev. I was asked by Dr. Anish Bail, a very good friend of mine who stays in Mysore with me, about this concept of mind over matter, or mind-body concepts, etc. And these three concepts or these three phrases that have been used are fantastic. The first one is synapse. Today, we are probably encouraging synaptic activity between many of the brains that are going to take part in this through mind-body, whatever you want to call it as. It's fantastic, I tell you. Brought by sphere. It's a full circle. Start here, sphere takes us around and it's a full circle. And when the circle is built, synaptic ramification shall happen. Beautiful concept. Dr. Vaishali, fantastic. Hopefully, I will do justice to what is going to happen in the next 25 minutes. Look at this picture. Can you find out where the boy is sitting? What is the boy's or the man's legs and the female legs? Sometimes when you look at it, you get really confused. Same thing here. Head and a black shirt of the man, or is it a pink shirt of the man? We get confused. Classic example is happening with the so-called evidence-based medicine that we are facing. We have been focusing mainly on one thing, medicate, so that we can probably bring down all the ills of the diseases that we are faced on. This is the exact problem that we are facing. On a bird's view, this is going to happen. Let me clear some of the ideas for you. This question, it's a false dichotomy. Meditate, medicate. Can you imagine our ancestors, as Shashank was talking about? They did not have TVs, they did not have lights, or they did not have any other things except hunter, gather, sleep, get up, and be happy. So meditation probably was predating to medication if you really look at our evolutionary activity. So it's a false dichotomy, whether to medicate or meditate, whatever it is, because it's not a matter of either or, because meditation is a very valuable addition in general to our life. Meditation, it's not 24 hours meditation. We'll speak about it later. And to therapeutic processes in particular. In general, meditation is very important for our life, a proper life, and in particular to the therapeutics that we are going to use. When there is hardly any health issues or a minimal change in our health, probably meditation is good enough. You meditate, heal thyself. Man, heal thyself. When the health issues are easy enough to handle, when it goes beyond a certain level where you cannot handle with yourselves, probably medication comes in. This is the socio-economic privilege being where the concept of recommending meditation over medication comes. Recommend meditation over medication comes because health issues are not that easy just with meditation or medication. It's more complex. We will not look at evidence-based activity for that. But once even today can continue with medication, yes, but meditation should be an integral part of whatever we do. I'm not going to give you much about it. Why? Because we all know lobar pneumonia is caused by a bacteria or a virus, etc., etc. But what happens in that particular individual who gets this bacteria or this virus and there is a lobe that is involved in infection is not just about the so-called biological component. There is a psychological factor for that and a social factor. So this angle G, need for a new medical model, is very, very, very important if you ask me. It is called psychosocial model of health and illness. So I think we should really give much importance here. I'm not going to delve very, very deeply into this. It's already there. Psychological factors, unemployment, financial stress, etc., etc. Socioeconomic status, educational status, interpersonal. So many things are there, and biological factors we all know about it. Unless we put all these three in the middle, we are not going to succeed in treating our non-communicable disease component of the problem that we face. So can you treat psychological factors with medication? Can you treat social factors with medication? Can you treat biological factors with medication? Think again. The second concept is we, the modern medicine specialists, are very happy and proud to say that we have increased lifespan. In India, lifespan has gone from 30 years to 40 years to 70 years to 69 to 72 years is the lifespan. But is it equal to health span? Have we ever thought about it? Earlier, why we were not seeing many diabetics, probably most of them were dead with a cholera or some pneumonia or some influenza. By the time they were 20, 30, probably 40 years. Now that we have increased the lifespan of our patients or our population, they are going to live till 70. Imagine they develop diabetes at the age of 45 or 50. If the lifespan is up to 70, they have 20 years of life where they have to safeguard their health. This is where we have to introspect and say, do we equate lifespan with health span? This is very important because I feel in our day-to-day conundrum of treating a type 2 diabetic, health span is as important as lifespan. Lifespan has increased, yes, 79 years. It's a US-based activity, but health span is only 63. They develop diabetes at the age of 40, 45, 50, up to 63, 64 years on an average, they are very healthy. Then kicks in microvascular, macrovascular, heart attack, kidney failure. But with so-called, technological explosion and scientific discoveries, we can still make them live, but up to what? With very little health. So this is where we introspect. We should also see that lifespan and health span come very, very near to. The health span is 68 years and lifespan is 70. It doesn't matter. 1 year, it doesn't matter to your patient, right? You agree with me, I hope. Now, diabetes is fundamentally a chronic metabolic disorder. We all agree. Yet it has established psychological connection with consequences. I was talking about psychological, social, and biological. I want to bring in that connect because the most important component is diabetes distress and coping with this distress. And you have all these components of burden of living with chronic disease, fear of failing, keeping up with diabetes care, fear, angst, despair, living with, all these things leads to diabetes distress. How does the person with this diabetic distress cope? This is very important. Can he or she cope with the diabetic distress that we are talking about it, can he or she cope with just medication? Think again. These are the sources: powerless, negative social. Concepts are very much available. All you have to do is take a textbook, take a journal, Google, you get all these things. I would like to draw your attention to this. Diabetes is non-communicable disease, chronic metabolic disease, agreed. But there is a psychological and a social significant component which leads to diabetes distress. And the best way to cope is not just medication, you need to go beyond. I want to tell you is meditation also. Okay? Then, quality of life, you all know so many things, significant issues and challenges at physical, emotional, psychological, social, occupational, and interpersonal level. All these things put together, there is a burden on the diabetic. Quality of life goes down. It's this is again theory, constant monitoring, maintaining normal blood glucose, whether your wife, your husband will look at you suspiciously, or doctor will keep talking, what is this? I've been telling you to take care of yourself, you're not doing. Constant input that you should take care of your diabetes, consistent use of anti-diabetic drug every day in and out, fear of especially hypoglycemia, all these things add on to the distress, which leads to a decreased quality of life. And one more component I would like all of you to really look at your type 2 diabetic from today onwards is diabetes associated cognitive decrement. There is cognitive decrement which is associated with hyperglycemia, not necessarily only with advancing age, which many times it is called as minor cognitive impairment and probably ignored. Keep this in mind. Hyperglycemia, tell them your cognitive decrement is going to happen with hyperglycemia, which will lead to you forgetting certain things, you ignoring certain things, enhancing diabetes distress, leading to quality of life going down. Vicious circle. Okay, keep this in mind. The result, decreased quality of life in whatever way you want to talk about it. Result, distress increase. Result, outcomes are bad. Result, health span is going to shrink. Added to that are the personality characteristics, psychosocial issues, peer pressure, family dynamics. Everything gets into the conundrum of helping a type 2 diabetic. It's not just medicating them. 5-factor model, I hope all of you know about it, or you please make your homework about this 5-factor model of personality characteristics. Openness. Doctor should be open with the patient. Patient should be open with the doctor. Everybody knows. Conscientiousness. Extraversion. It should be a little bit, Shashank was telling, smile. Put a smile on your face. Half of your problems may come down. Agreeableness. Please agree with what's happening around you. Accept what is going to happen and go from them. To a certain extent, don't laugh, neuroticism. You need to be a little bit neurotic. That inner thing that has to be brought out that you're going to do well. Why I brought this is the classic antipsychotic problem that happened in neuropsychiatric prescription with metabolic disorders. You all know AP-induced metabolic alteration, AIMA. AP, that is antipsychotics induced, leading to appetite dysregulation, obesity, dyslipidemia, type 2 diabetes. It's very well known. Weight gain is significant with antipsychotics, and that pushes them towards type 2 diabetes or known type 2 diabetic. Weight gain, very bad. Blood sugar control. Upregulate, downregulate, upregulate, appetite inducing peptides. So you start eating without your knowledge. Downregulate anorexigenic peptides. Again, these are all theory that why I'm trying to tell you is the drug, that medication also leads to this diabetic distress, abnormal outcomes that we are talking about. And what is the, physiological and neurological substrate? You all know hypothalamic nuclei and, ventro, all these, ventromedial nuclei, everything that comes into picture. Animal experiment, neurophysiological substrate. Finally, it is energy homeostasis. What is this? Allostasis, very fantastic lecture that happened. Insulin, insulin-like growth factor, all these hormones, 8 or 9 or 10 hormones, try to keep a homeostasis. There is abnormality because of psychosocial, because of biological abnormality. Allostasis goes on, and after some time, homeostasis goes for a 6, leading to all this problem. So, this one thing I just wanted to insert, it is way out of my purview of talk about a lot of interest has been shown in this particular path towards research called as transient receptor potential system, TRP, not your, all those, how do I say, TV TRPs, various subtypes of TRP channels, which are basically influx of cations such as sodium and calcium. Keep this in mind. Remember verapamil and type 1 diabetes emerging, it's going to protect. You're probably looking at TRP. TRP channel family comprises 30 different group 1, group 2, everything is there. Just I insinuated this because this could be a very potential field of research in future. Lastly, I come to meditate versus medicate. I have deliberately put a gap here because this is where a conscientious doctor like you and I or every one of us walk in, called as mediate. Meditate, medicate. In between, there is what is called as mediate. The person who mediate is you. You need to understand it in a proper manner. Okay? Meditation process, I'm not going to talk much about it. I'm not an expert in that. But 5 minutes, 10 minutes meditation, calm about it. Anybody questions? How I meditate, I'll let you know. Mediation is something you really have to understand. Practice of working with someone trustworthy. So it is bi-directional. You trust your patient, the patient trusts you, and if that practice of working with someone trustworthy, balanced and impartial will support you, the patient, support physician also. Keep in mind, mediation is you initiate and it is a bi-directional activity. Referred to as CPR of conflict resolution in psychology. Okay? Now, look at this slide. What do you understand? Everybody is smiling, looking at this matriarch or patriarch of the family who has reached the heavenly abode. Do you think this is the inner thing that you have? Looking at this, they are posing for a very nice photo. But are they very relieved that this old person died? Or they are celebrating this old person's long life? This is where you really have to think about how you respond. I didn't understand this picture. Please explain. That's what I'm trying to tell you. Please respond in a proper manner to your patient's needs. Trust in patient-doctor relationship is the final thing that I would say. Stop. Okay? Many theories, few measures, and very little. There are plenty of theories. I can talk to you about this for 45 minutes. Very few measures, how you can go about bringing down the distrust in a patient when a doctor is concerned. Absolutely very little data is available today. But issue is, patient doctor trust me, I'm your doctor. Trust me, please. I want to do the best for you because doctor knows best. That is literally gone from the concept. The concept of trust today is top-level commitment, risk assessment, undertake control measures, systemic review, monitoring and enforcement, training and communication. This trust is classically relevant in non-communicable diseases, especially so in type 2 diabetes and hypertension management. So, trust principles, start internalizing. Don't say doctor knows best. Think of how you react with your patient. Things are done. I decide for you, paternalistic model, not anymore. Deliberative mode. In addition, I tell you my preferences. Then I give you facts, informative model, and I give you facts and help you to find your preference and interpret it. Today, a doctor has to don all these four. Paternalistic model with trustworthy patients who trusts you till their death. Deliberative model when the patient is a little bit doubtful about your standards. Informative model when patients are highly educated, they come with Google University or WhatsApp University degrees. And interpretive model is what we are talking about, doctor-patient. Paternalistic, deliberative, informative, and interpretive. Interpretative manner probably would be the way to go. But you have your patient for the last 20 years, paternalistic. I decide for you, don't worry, let me take care of it. Yeah, it still works. And it's complex illness and treatments, interactions are changing, healthcare systems, increased patient expectations, blame and complaint culture, litigation, diversity, resource limitation. All these things are just theoretical consideration. Plenty of theories are there. Very little measures to take care of this complex illnesses and treatment measures. That's why you need to talk about building trust with your patient. It's a cycle. You should be competent as a doctor. You should be dependable, honest, and considerate. Empathy, all those theoretical phrases that you can use. If you have competency, you are dependable to your patient, you are honest enough in telling them what's going to happen, what I know and what you should know, and you consider it for their psychosocial needs, you will definitely be a trustworthy doctor as far as your patient is concerned. Medication is the outcome of process when we give another person the power to make a decision on our behalf. The patient, I'm talking about the patient gives the power to the doctor to make a decision on their behalf to medicate, and they have to follow, and that's another conundrum we are talking about. So the decision-making person goes through a process of analysis, diagnosis. That's you, doctor. The decision-making person decides by analyzing evidence which has been presented in legal proceedings. This is nothing but history taking, general examination, systemic examination, tests, that, this, and all that. But decision-making person, why? The patient has put complete trust in you, have given you the power to decide for him or her to give a prescription for medication. So the decision-making person prescribes an answer or a solution at the end. That's your problem. That is medication. How do you do that? Please meditate yourself. Help your patient to meditate. Mediate all these things that I've just mentioned. Then start medicating. Win-win situation for both patient and doctor. Finally, you take medicine. Please tell them. Finally, with all these things that you have done, you take medication. I can't take medication for you, my dear patient. You take the medication. Remember, medication is likely to be, fill up the blank, problematic, the most expensive option. So to meditate, you don't need plenty of money and you need all sorts of things. To mediate, all you need is a good heart, good understanding brain. Medication is probably the most expensive option that you can think of for your patient. Keep this in. Okay, build and maintain trust. These are all theory, don't worry. These are some of the things, you can ask them to give these two very good topics that they have dealt in, meditation and meditation as medicine. You can go ahead. Finally, ladies and gentlemen, put a smile on someone else's face today. I hope I put a smile on you all. Thank you.
Thank you, sir, for that wonderful talk. We all get to learn from your talk, and we all get the take-home message for ourselves as well as what we advise to our patients.